Welcome to Progenesis Academy webinar session number 13. Today we are hosting a webinar, a roundtable discussion focusing on fertility treatments and success rates. And we have a great number of participants, both both IVF professionals and patients. We're going to be taking some questions directly from patients to our panel of experts. It is my pleasure to welcome our panel of experts, Dr. Allison Rogers. She is a fertility specialist at FCI Fertility Center of Illinois. And we have Dr. Deborah Wachs, and she is the fertility specialist at Reproductive Science Center of the San Francisco Bay Area. Thank you so much for joining.
Thank you.
Thank you.
Very good. So I've been asking, in the last webinars, I've been asking pretty much the same question at the very beginning, which is regarding COVID-19 pandemic. And can you tell us a little bit how you're adjusting to COVID-19 in terms of your protocols and the way you are handling patient care? And I will start with you, Dr. Rogers, and then after that, we'll go to Dr. Wachs.
Yeah, so obviously it's been several months now, and so I think most of us have had plans to adapt things. In our practice, we are screening all of our patients for COVID-19 at the beginning of treatment cycles. And if they're testing positive, then we have to allow them to be, go through their virus and be healthy before we can move forward. We're also spacing patients out. So we're really spacing monitoring appointments out. We are, cleaning. Obviously, we always are pretty sterile and clean between patients, but we're making sure everything's sort of wiped down, things that might not necessarily potentially otherwise need to be wiped down. And we, from a procedure standpoint, are really spacing out, for example, like retrievals. We're spacing out the time between retrievals so there's less patients in the office. We're not having spouses join, which is difficult for patients, of course, because they want their spouse to be there, the patients who have spouses. But we're trying to sort of really minimize interactions between all sort of staff and patients. And then we're doing a lot of our visits through telemedicine, which really protects everybody.
Very good. Thank you so much. Dr. Wachs?
I'd echo much of what Dr. Rogers said. We closed down completely in March when the shelter in place and quarantine announcements first came out. And then we slowly started back up again. At first, we were at about half of our usual volume in terms of IVF. We're doing similar in terms of every patient gets their temperature checked at the front door before they're allowed in. We've spaced appointments out greatly. So our waiting room only has one patient at a time. That one patient gets ushered into the ultrasound room or blood draw. Any patients that need to be seen for an in-person visit come in, but no partners are allowed as well, just like Dr. Rogers said. And then for retrieval time with anesthesia, we are assuming all of the highest precautions we can in terms of masks. Patients are wearing masks. Monitoring is heightened as well, but very similar to what Dr. Rogers said, trying to allow patients to continue to cycle, but doing so as safely as we can.
Fantastic. Thank you so much. One of the questions we have had many times in previous webinars was regarding the amount of information we currently know about COVID-19 and the impact on pregnancy. What do we know so far? Dr. Rogers.
Obviously, this is a new virus and we're learning a lot of things. And I don't think we have all the answers quite yet. What we do know is that unlike other viruses such as varicella, rubella, Zika, that the COVID virus does not appear to cause birth defects, which I think is very reassuring. We do not at this time see increased risk of maternal mortality, but obviously there's a lot to learn. There's some research trials going on right now for IVF patients who are early in pregnancy, trying to figure out if there's increased risks with pregnancy and getting COVID. But right now, it seems to be very reassuring. I think that we're trying to gather as much information as we can. There have been some reports of sort of second third trimester, maybe stillbirths or miscarriages. And the question is, we're trying to sort of figure out, are those related to COVID, or were those patients who were going to have, a miscarriage or stillbirth anyway? So I think that there's still a lot to be learned. But really at this point, there's no organizations that I'm aware of that have said you shouldn't be trying to get pregnant right now. There's nobody saying you shouldn't get pregnant. Obviously you want to do what you can to protect yourself, but that's for everybody, whether you're going through fertility treatment or not.
Thank you so much. Dr. Wux?
Yes, I think patients who are going through fertility treatment have a potential benefit of being able to freeze their embryos. And if they were worried about getting pregnant now while things are still new and information is coming in, freezing embryos is something that would absolutely give them the benefit of time and knowing what quality of embryos they have frozen, how many they have frozen, so that if they wanted to wait and not do an embryo transfer until we understand more about the virus or things settle down, that's one great option that fertility treatment allows. But just like Dr. Rogers said, I mean, right now the American College of Obstetrics and Gynecology is not telling fertile women that they should not be trying to get pregnant. Women are not being told to be on birth control. So while the guidelines are pretty reassuring that we all have to be cautious, but we have no strong reason right now to tell women they can't get pregnant.
Very good, very good. Thank you so much. Let's take a couple of questions from patients. Miriam is going to help us take those questions, and then we will address them. And after that, I'll go with my questions afterwards. Miriam?
Sure. First question is from Candace. She's 37 years old. She had 26 eggs that were retrieved and 7 embryos were tested. Out of these 7 embryos, only 1 was normal. So Candace asked, what can she do to improve her egg quality?
I will start with the same order, so we keep it the same way.
I wasn't sure who the question was going towards. Okay, so this is a patient who is 37. Clearly, she's having a lot of eggs, but not a whole lot of healthy embryos at the end. And, there's, in the patients who have a lot of eggs and not as many healthy embryos as we had hoped, there often can be, this is part of the infertility. So these kind of things are what's happening in her body every month, and probably egg quality or embryo quality is part of the reason why, she may be having trouble with infertility. The hard part is that we're born with all the eggs we ever have, and we don't get more. The idea of supplements, in my view, is to really sort of support the growth of the healthy eggs that are there, but we can't do anything to get more eggs. I certainly think that if I have a patient who has a cycle where there's a lot of quantity and not a lot of quality, then there's certainly some supplements that we can add in. And I would encourage everyone to talk to their doctor about what supplements their doctor recommends and what would be good for them. But, I think that supplements like CoQ10, like myo-inositol, potentially DHEA, those, some antioxidants can be helpful in melatonin even in certain circumstances, but that's definitely something you should talk to your doctor about, whether that's right for you or not. And then I think that it's always a good idea to consider changing up a protocol to sort of focus maybe on quality and not quantity, because, I tell patients all the time, I'd rather have 1 egg that will make a baby than 26 that won't. Obviously, we don't want just 1 either, but we want to focus on quality as well. And sometimes adjusting a protocol, which sometimes results in less eggs, but maybe healthier embryos, may be something this patient wants to talk with her doctor about.
Very good. Dr. Wux?
In that scenario, we don't know the specifics of, did she make 7 beautiful high quality blastocysts, but chromosomally only 1 was normal? Because those are 2 different issues. If it's a quality of blastocyst issue in terms of the grading, there are times where we can add growth hormone to a cycle or try to improve the quality of embryos. I agree with what Dr. Rogers said. Sometimes actually a more minimal stimulation will get us fewer eggs, but potentially better quality eggs. If it's that she made beautiful embryos and 1 was chromosomally normal and the others were not, that's hard for us to modify. That's genetically, the embryo had too many or too few chromosomes. Sometimes in scenarios like that, it's a matter of trying again. Statistically, that was a higher percentage of abnormal embryos than we would estimate for her age, but it's also possible with a change in protocol and another try, she may end up on the other side of that statistic with 2 or 3 normal embryos in the following month.
Very good. We looked at our data, our aneuploidy data based on more than 30,000 embryos. And we see 54% is euploidy rate. So if you are 37, you should expect 54% of euploidy. So this is definitely a lot less than what the patient is reporting.
But remember, it's a single sample size. So with 7, we would have expected hopefully 3. And in that cycle, she got 1, but it's too small of a sample size to draw that. Patients say that all the time. If it happened once, how do I know the same thing won't happen again? But it's too small of a sample size to draw conclusions that make us feel so worried. Now, if the same thing happens in a second cycle or hopefully not a third cycle, that's different.
Yeah. Miriam?
Next question we have is from Jenna. She's 33 years old and she's been trying to conceive for 2 years. She has a low AMH and low antral follicle count. What protocol, or she asks, what protocol is recommended for a patient with low antral follicle count and low AMH? And then if a patient has a low number of mature follicles, would you advise the patient to do an IUI and cancel IVF?
So there is a lot to that. So there's a lot to unpack there. First of all, what I would say is that, you know, your specific doctor can sort of talk to you about pros and cons of different protocols for you. Typically for a patient who it's their first IVF cycle, I have to sort of use the AMH, and we say it's low, but we don't know exactly how low, right? We have to sort of use the AMH to come up with a protocol to sort of help them be as successful as possible. Everyone does things different and there's no right or wrong way to do it. So you ask 10 fertility doctors what protocol they'd pick for that person, you get 10 different protocols. But typically for patients who have low AMH, I typically don't put them on birth control pills. And one of the reasons that I don't is because I find that birth control pills over a long time can be over suppressing, but a lot of people do and their patients do fine. I also don't batch my cases. So we do cases, you know, 7 days a week. And so, you know, all month long. And so in centers where they're batching cases, they need to be able to line a patient cycle up to when they're doing the IVF procedure. So some, you know, everyone's a little bit different. I think that, you know, to start with, I'd probably use a higher, if someone has a low AMH and they're 33, I probably would use a higher dose of gonadotropins than I normally would for someone who's 33 based on their AMH and their age. To expect them to need a little bit more to help them sort of from the beginning. And, you know, typically part of whether we need to cancel and change to IUI or whether, you know, we add in things like Dr. Walk said, like growth hormone or other supplements, or whether you're doing a microdose Lupron flare or an antagonist protocol, right? Those are all things that partly will depend on the patient's history, exactly what their fertility issues are, and then also insurance coverage. You know, I have patients who have maybe 4 IVF cycles in a lifetime, and maybe they're on cycle number 3 or 4, and they're having a horrible cycle compared to sort of what they're usually doing. Those are patients we may consider canceling. I also have patients who have no insurance, right? And part of the decision to cancel or not depends on sort of what we think the potential is and if they're hitting that potential. If, you know, every cycle is different. In some cycles you have more follicles accessible and sometimes you don't. And it's really important to be able to have a good communication with your doctor and your team to try to decide whether you want to continue a cycle or not. And that's something that's obviously really individualized and, you know, a discussion, because maybe for this patient who's 33 with a low AMH, maybe 3 or 4 follicles is the best she can do. And having 3 or 4 follicles is like an amazing cycle for her. But another patient who's 33 who maybe has a normal AMH, if she got 4 follicles, we'd be like, oh, that's a horrible cycle. We expect her to get 10 or 12. So really it depends on your situation.
Thank you so much. Dr. Wax?
So age is a really important factor in this discussion. She's got young age on her side. And just like Dr. Rogers was saying, it's possible that for a young woman with a low AMH and a low antral follicle count, she may have a lower egg yield, but the quality of those eggs may be great. In terms of the decision about how to decide if you're going to go to egg retrieval or not when there's a low number, I think it depends on what she's done already. Sometimes patients come to us, they've already been doing IUIs for 6 months. It depends on the sperm. Are sperm numbers good enough that we can anticipate that an IUI has a reasonable chance? Are her fallopian tubes open? So those facts come into play to determine how good of a candidate is somebody for IUI versus IVF. If we see that the antral follicle count is less than 5, it's possible that no matter what protocol we pick, a high dose or a more minimal stimulation, we may get 3 to 4 good looking follicles. And if we determine that that may be the best that this patient's going to do, then there are times where we will want to let her get to an egg retrieval if trying on her own or trying with IUIs hasn't been successful up until that point.
Very good. Have you guys done IUI on a patient that was originally planned to do, traditional IVF because they had low follicle number?
Sure, and we even have patients who get pregnant.
Very good.
Yeah, that's the best.
Very good. Miriam, next question.
Actually, Jenna had an additional question. So she's also planning on doing genetic testing with Progenesis. She would like to know what your thoughts are for transfer of a poor quality embryo or an abnormal embryo.
So I recommend, if you're going to do genetic testing, do the genetic testing and put in the best quality euploid embryo. I don't know about Dr. Walk's practice, but we do not transfer abnormal embryos. And I don't also recommend transferring the poorest embryos because those are not, obviously we want to help you be successful, and putting in the best quality embryos first will help you get there.
But if you have only poor quality embryo, would you transfer them?
If they were genetically normal, yes.
Okay. Dr.
That's
Walk?
where your embryology team is super important. Our embryologists only biopsy and freeze embryos that have a good chance. So there's no point in telling your patient she's got 6 embryos frozen if you know inherently that the quality is so poor that it's not going to give her a good chance. So we rely on our embryologists to biopsy and freeze good quality embryos so that when we get that result and we learn how many of them are chromosomally normal, we know already that those are good embryos. Just like Dr. Rogers said, we do not transfer abnormal embryos. And so I always tell my patients, if you're doing PGT testing on your embryos and you're doing it because you want to know which are the normal ones, then when we get that result, we need to follow that result.
Very good. Let's take another question, Miriam.
Yes. So our third patient had several questions, so I'll kind of just go 2 by 2. So she is 33 years old and she's been trying to conceive for 1.5 years. Her AMH was low for her age, and she was later diagnosed with endometriosis. So her first questions are, what do you think is the main issue with endometriosis and infertility? And how does asymptomatic endometriosis lead to infertility?
Those are good questions. I think whoever figures out the answers to those questions will maybe win a Nobel Prize. But let me try to take a stab at it. We'll see if what Dr. Woggs has to say. So I don't think we totally know, right? We don't totally understand all the details about endometriosis and why it causes a problem. Now, there are some things. So, for anyone who doesn't know, endometriosis is where the lining of the uterus, which is supposed to come out through your uterus, through your cervix, through the vagina, can go backwards through the tubes, and it can land on places it's not supposed to be. So the glands inside the lining are supposed to just get dissolved, but for people with endometriosis, those glands land. They can land inside the tube, they can land on the ovary, they can land on the ligaments behind the ovary, causing pain, bleeding, and scar tissue with every cycle. And, when we think about, some patients certainly can have structural issues, right? And I feel like I probably have a picture of it right here. But I don't know if everyone can see, but we look at the inside of the tube. The inside of the tube has this very delicate architecture. So it has these fimbria that pick up the egg and bring it back. And you can imagine if there's microscopic endometriosis there, the tube may be open but not functional to pick up the egg. And you can imagine if there's microscopic endometriosis there, the tube may be open but not functional to pick up the egg. And then there's also, potentially something about the endometriosis, which sort of will sit on the very outside of the ovary that can cause damage to both quantity and quality of eggs. But the bottom line is we don't 100% understand exactly why this happens. And I think that, there's plenty of women with endometriosis who have, no issues with infertility, but certainly there's patients who have sort of asymptomatic endometriosis. So, the two signs of endometriosis are pain with cycles or intercourse, and then also infertility, right? So infertility is a symptom in of itself, but there's certainly patients who don't have any pain. So I think that's what, she's sort of talking about in terms of asymptomatic, that still have infertility, because pain and the severity of your endometriosis do not correlate, interestingly.
Dr. Wachs?
I agree with everything that Dr. Rogers said. We approach a patient who we know has endometriosis with all the tools that we can. We try to keep her estrogen level lower while she's doing a stimulation. We may utilize a protocol as well during her embryo transfer, which also will keep her estrogen levels low. If she's got a big endometrioma on her ovary, and many patients, that's the way they're diagnosed, is on an ultrasound, we will see a big endometriosis cyst. That can impact the amount of normal tissue present in the ovary. That's one of the reasons why AMH can be lower. We have to help the patient decide, is there any role for surgery? In many patients, we tell them the role for surgery may end up hurting them more than helping them if the surgery itself is going to cause more damage to the ovaries. So it is a subset of patients we see a lot of. And just like Dr. Rogers said, we don't know exactly which step along the way the endometriosis may be impacting any one particular patient. But if they've been trying on their own and they've been trying with IUI and they haven't been getting pregnant, it's very possible it's more of a mechanical issue, like the fallopian tubes and something about the sperm and the egg not being able to meet. And that's why IVF can be quite helpful in these patients.
Very good. Thank you so much. We're going to pause on those questions. We have one patient that is live that want to ask a question live. Riley, do you have a way of getting the patients in?
Hi, Fiona.
Hi, can you hear me?
Yes, we can hear you.
Great. There's my name. First, I wanted to say thank you to both of you for your time and taking the time to talk about this tough topic. So thank you.
You're welcome. This is what we love. We love doing this because we do this every day. This is our passion.
And we love you for it. So basically my history is last year, after trying for 6 months with my husband, we became naturally pregnant with twins, di twins. And then they tend to run in the family. At about 10 weeks, I lost them both, had to have a DNC, and eventually ended up with a fertility specialist. We found out my AMH was 0.19. We then tried an IUI, it failed. And then we started Retrieval Cycles, which I did not respond very well to either. We did 4 Retrieval Cycles. 1 was canceled. I guess my estrogen was really low, so they didn't think it yielded any good eggs. Out of the other 3, we got 1 embryo each. So I have 3, I'm told, good embryos that were genetically tested by Progenesis, thank you. And they were also normal. I have a normal TSH, but I do have thyroid antibodies. We have not implanted anything yet. I just finished a hysteroscopy to remove some polyps, which I'm told was from the hormones themselves. I guess my question or questions are, what are my chances of a successful implant? What are my chances of conceiving again naturally if and when I run out of my 3 embryos? And then what are your thoughts on purposely or voluntarily implanting 2 embryos for twins?
I will start, I guess, since I'm
sorry
for all of them. So first of all, I'm so sorry to hear about your loss, Fiona. Obviously that's devastating, and I don't know if they were able to do any genetic testing to see if there was any other explanations for you, because obviously that's late.
They did, actually, if I may interrupt, I'm sorry. One was a female trisomy 14, but the other one they couldn't test.
Okay.
So
obviously that could be an explanation. And women who have lower AMH, often as we lose the quantity of eggs, a lot of times we lose quality of eggs too. And so, and how old are you? I didn't catch that.
Yeah, I'm now 37.
Okay.
I had my AMH retested and it was
Younger
0.
than me. That makes you young. You're younger than me. That makes you young.
I'll take it. I'll take it. I had my AMH retested and it came out to 0.89.
So what I would say is that, you know, part of the decision about sort of what your next step should really be a discussion between you and your doctor about your family goals. If your goals are to have just one child and that's all you want, obviously that'll be different than if your goals were to have 3 children. And so I think it's really important to sort of have that discussion with your doctor about sort of best ways forward and, you know, what your particular goals are. And I think that a hysteroscopy with polypectomy is a great step. I think that if you were somebody who said, I want 1 or 2 kids, I would probably recommend moving forward with a transfer. If you were someone who said, you know, I've only 3 embryos and I would really like 3 kids and I really, you know, have, you know, of course, and I would maybe consider some additional testing like potentially an endometrial receptivity array assay to sort of look to see if there's a limited number of normal embryos to make sure we're putting the embryos in at the right time. I would absolutely recommend 1 at a time. I will just speak to the fact that you've obviously already lost twins, and twins give you a very high chance of loss. And unfortunately, as you know, sometimes you lose the baby so early they don't survive. Certainly, sometimes you lose the baby so early they survive with lifelong problems, and then you have 2 sick children. Our bodies are really designed to have 1 baby at a time, and there are national guidelines. This isn't something that Dr. Walks or I are making up. There are national guidelines that recommend that it doesn't matter if you're 20 or 45, if you have a genetically normal embryo, you should really just put in 1 at a time. Because the risks really outweigh the benefits. And I was a fertility patient. I had to go through fertility treatment. And when I was doing this, I think I felt so hopeless that it was never going to happen that I wanted them to put in more embryos. And, you know, obviously being on the other side of the situation is a very different place to be. And I think that the truth is that a genetically normal embryo has an excellent chance of being successful. And so, you know, putting in 2 doesn't increase your chances of success. It just increases your chances of twins, which sound great when you're on the other side. But I'll tell you, the patients who have twins who then lose them at 22 weeks, I am not a fan of those phone calls. And it is heartbreaking to see patients who have babies at 24 weeks who have lifelong problems. And, you know, obviously a lot of twins are born fine, but a lot aren't. So I'll let Dr. Walks, you know, see if she has anything else to add here.
So I echo the sentiments around transferring 1 euploid embryo at a time. You were pregnant with twins, and I think for patients who've been pregnant with twins, the idea of trying to create that again, it can be an emotional decision there. But I would fully agree with transferring 1 at a time. Regarding your AMH, I wanted to just mention you're a great example for us of why AMH is not always a marker of how fertile you are. AMH is a marker of the pool of eggs that you have. And we see women all the time who have a low AMH, but it doesn't mean they're not going to get pregnant next month on their own if they kept on trying. You only had your AMH checked because you ended up in the fertility doctor's office, but you also got pregnant on your own with a twin pregnancy. So you've now lived through the IVF, and one of the consequences of a low AMH is that we often have a lower number of eggs and a lower number of embryos. So it took you 3 cycles to get, no, I can't remember if you said it took you how many, but it took you multiple cycles.
Yeah, it was 3 cycles and I got 3, 1 cycle.
So,
yeah.
Right, it took you 3 cycles to get 3 embryos, and maybe somebody with a high AMH would have done 1 cycle and gotten 3 embryos, but you did get 3 embryos, which is a great place to be. I agree that we can assume you have a proven uterus in that you had implantation occur on your own. The miscarriage most likely was due to the chromosome problem that was detected when they did the testing. Just like Dr. Rogers said, if you, the ERA test is something we do a lot of. We tend to do it if a patient only has 1 or 2 embryos, or if they want to know that they've done as much evaluation as possible before transferring the embryo, because we are trying to recreate the setting where your uterus is going to be most receptive to that embryo. But I think you're in a great spot to have 3 chromosomally normal embryos and a uterus that has proven implantation.
I agree.
Real quick, do you think, what are my chances of conceiving again on my own?
That's where I would ignore that AMH potentially. Okay. So again, you may not have ever had that measured, and you would have been walking around happy as can be thinking you were fertile because you'd had that pregnancy on your own. And you, at 37, you're in your window now where a spontaneous pregnancy is more likely to happen than if you have one baby from one of your frozen embryos and then you're trying on your own again when you're 39 or 40, your monthly chance will certainly be lower. But I do think it is possible that you could get pregnant on your own, and I wouldn't let the low AMH scare you.
Thank you so much.
Would you recommend a karyotype for patients who had a pregnancy with a chromosome 14 abnormality?
Not necessarily. If she had a history of recurrent miscarriages, that's different. It's possible that depending on the products of conception testing, that it leads us to be more suspicious. It's always, you can always make the argument to do the most testing on everybody and then you'll never miss something like a translocation. But with one miscarriage, we don't necessarily go to karyotypes right away.
Very good.
Thank you.
Yeah, I agree. I think that it's a really case-by-case situation, obviously. And I, of course, I'm forgetting off the top of my head the name. Obviously, there's a couple chromosomes, like I think
Robertsonian.
Yeah, but there's a couple chromosomes that are small that have a higher chance of getting stuck, stuck to each other with that
Robertsonian translocation.
Right, but there's some of the, it's not all chromosomes that are higher risk. 14 is one of them that is higher risk, as is 21, 22, right? And so, and 13. So I think it would have to depend. The other thing is I certainly have patients sometimes who have PGT testing, PGTA testing, and then I've definitely picked up where several of their embryos have the same chromosome, either missing or added, and then I'll check them. And sometimes it's just random, but sometimes there is a translocation there. But I think one miscarriage with a trisomy, it's likely just, was, an unhealthy egg, unfortunately, and it's probably not a translocation situation. But obviously IVF with PGT would hopefully tell us that as long as the segments are big enough.
Yeah, very good. Thank you so much. Before we take the next question from patients, I want to ask you guys about the success rate. Do you estimate success rates during your consultation with the patient? Do you tell them what is your success rate and this is this percentage or that percentage based on how many recurrent pregnancy loss you had and your age, AMH, etc.?
Yes.
I'll start with anyone. The first.
Okay, I'll jump in. So yes, that's of course, first and foremost on every patient's mind is what's the chances that this is going to work, depending on what their history has been, what they've gone through leading up to that initial consultation with us. We're often able to be pretty accurate on that first meeting based on their age and their history and hormone factors to give them a sense of what their percentages are for getting pregnant. In our clinic, we try very hard to analyze our data frequently. And by doing that, we're able to be very accurate and up to date with the success rates that we're quoting. One of our embryologists, he's a bit of a data geek, and he's constantly creating methods for us to be evaluating pregnancy rates. We have a PGT calculator where you can put in the grade of the embryo, and he has accumulated all of the patients and put them in one embryo at a time, so we can calculate for our patient what's their chance of getting pregnant based on the grade of that embryo. But I think another reason we are able to look at our data frequently is we're 6 physicians in our group, but we try to really be uniform in terms of the protocols that we pick, the patients that we're cycling through, so that when we take a step back to look at our outcomes, we are looking at a larger group of patients that have all been evaluated similarly, and we can look at the protocol and their outcomes to give a great sense of what their chances are for getting pregnant.
Very good.
I would say that our practice does something similar. So we have 11 physicians and, so we definitely utilize the data. We're a big, busy practice, and we can look at our data from our own patients who are cycling of the thousands of cycles we do every year. We also actually look internally and we'll make sure that everyone is like up to the standard, and everyone's transfer rates are, in a nice tight window. If someone seems like they're falling out of that, or going too low, we sort of give them some extra training. We have them shadow somebody who might be on the higher side. And then similarly, if there's a couple providers who are on the really high side, then we do some internal analysis and sort of see what they're doing different, and really try to keep everybody doing amazing, of course. And I would also say that we definitely, I don't personally look at the CERT data across the country to give patients guidelines, just because our data is different. It tends to be about 10 to 15% higher or so, maybe sometimes. So we tend to, I tend to be able to give patients a little bit more of an accurate estimate about sort of their chances of success based on, again, age and prior success, AMH, and sort of what we expect them to do. And we can sort of look internally at our data from our lab, our patients who are sort of similar, and be able to guide patients on what to expect. And remember, the SART data that's published is 2 years old. So, things that happened 2 years ago are already not what's happening now.
Very good. How does the IVF technology look like in the future? Do you see the use of AI, artificial intelligence, in more towards, prediction of outcome and adjustment of current protocols, for example?
I think that our minds can only begin to fathom where the future will be. I do say that this is a field that is sort of moving at warp speed. Things that we were doing 5 years ago are already out of date. And I think that remember, the first IVF baby was not that long ago, right? So I think that it's important to know that technology and things like artificial intelligence are going to be really important moving forward. I know we were involved in a study with artificial intelligence where we had a computer sort of helping us. It was a study looking at embryos to see if the computer could predict what we thought was the best embryo. I don't think we were as impressed with it as we had hoped. It was a research trial, of course, but, I think that our embryologist did a great job and the computer didn't always quite get it right. So I certainly think, obviously, there's a lot of research to do. I think where this field is going is potentially artificial intelligence for storing embryos and minimizing any errors, potentially writing everyone's name in itty bitty writing with their date of birth on little bitty writing on every tube and every dish and everything. There's a lot of transposition that happens. And obviously our embryologists are amazing and so good at what they do. And there's double checks and triple checks and 100 quadruple checks. But, there's always room for error there. And I think that moving to systems where there's, printed labels, barcodes, those kind of systems to try to minimize error from an artificial intelligence perspective, I think is going to be interesting. And I also think there's going to be some really interesting sort of potentially non-invasive PGT testing coming out, and some sort of newer things that we're just sort of like on the brink of discovering in terms of sort of some of the genetic stuff and that. But it's getting just more amazing and more amazing.
Fantastic. Dr. Wax?
Yes, I think that we will never stray from the fact that these are individuals who come to us with their own story. And I think that's what we love about it. Every time we meet a patient, it's a mystery that we get to solve. And so I think that the role of technology and AI will likely increase in terms of some of the things that can be more automated and where technology can play a role. I think you have a very willing audience with the physicians and the patients. I think that we are a field where the doctors love to know what's new on the horizon, and the patients are definitely game for trying what's new and what might help them. It's important for patients to remember that the next new thing needs to be proven before we start to implement it and implement it with confidence. So I think sometimes patients hear little snippets here and there of what's on the horizon and think, why aren't we doing it tomorrow? And it's important to remember we're intrigued by all the same things you are. We just want to make sure that they actually work, and it's just not a new fad that is coming through and has promise but no real delivery.
Very good.
Point. It's a really good point because not every technology is good.
Yeah, but when you look at it, there are situations where AI can really bring a non-biased judgments in certain procedures, and technology can help physicians in certain situations make a more adjusted decisions. I don't know about IVF, whether that could be, but certainly in cancer and other type of treatments, the technology does help improve decisions in certain situations.
Absolutely. And I think if there is more testing that ends up being available for patients to learn more about their own potential, something about their own genome or their makeup that's bringing something to the table that we can specifically address, absolutely. I think we're not there yet, but I agree with you. There is certainly a role for this.
Fantastic. Miriam, we have the first poll. This is just a question, some questions that we're asking patients. Let's take one more question from the patients, and then meanwhile we can go, and after that we can go back to the poll.
Sure. We actually have more endometriosis questions. The next question we have is, what is the best treatment plan for someone with endometriosis, and can endometriosis cause a decline in ovarian reserve?
So endometriosis can cause a decline in ovarian reserve, mainly because, if the eggs kind of sit on that outer layer, the follicles with the primordial follicles sort of sit on that outside layer, and that's right where the endometriosis sort of globs onto the ovary. And we certainly see that ovaries that have endometriosis load on them you can have damage to your eggs from the endometriosis. And I don't think we totally understand why, or anything other than sort of maybe just the sort of structural replacement of the endometriosis growing there. And I would say that, in terms of treatment strategies, I think just like what Dr. Walk said, minimizing estrogen levels. So things like letrozole, which decrease estrogen levels, can be very helpful either on their own with intercourse or insemination, or added to an IVF cycle to reduce it. And also if patients have failed implantation, they have known endometriosis, sometimes I'll do either something like Lupron, which is a GnRH agonist, or I really like Oralisa, which is oral GnRH antagonist. So for patients out there who are listening who have gone through fertility, it's like an oral or tablet form of like Cetrotide or Ganirelix. And I like it because it's quick on, quick off, has a little bit less side effects. And the studies have shown, originally it was 3 months. Now I feel like there's some studies showing 2 months of suppression can be really helpful in terms of, increasing implantation rates, suppressing patients, and then moving forward with a frozen transfer.
Very good. Thank you so much. Dr. Walks?
I agree. I don't know that I have too much to add, and I'm sure people have more questions. I think protocol can be tailored to endometriosis, and I think that the decrease in ovarian reserve can simply be often anatomic, where the cysts of the ovaries or impact of endometriosis can literally impact the normal ovarian tissue and therefore the number of eggs.
Very good. Let's go to the next question.
So next question is, what is the required endometrium thickness for successful implantation? And then the patient also asks how to naturally increase endometrium thickness. So do factors like stress or exercise affect thickness? And then, yeah, those are the questions.
And Dr. Walks, can you start maybe, and then we go into Dr.
Sure. This question is close to my heart because I looked at our data about 2 years ago. I looked at 1,100 frozen embryo transfer cycles and looked at lining thickness. And we were really interested to see what ranges of endometrial thickness corresponded with pregnancy rates. And we generally look for the endometrial lining to be 8 millimeters or greater. And sometimes we go crazy trying to get that 8 millimeters. Most of our frozen embryo transfer protocols are estrogen protocols where patients will take either oral or vaginal estrogen and then have a lining measurement done about 10 to 12 days later. The thickness of the lining and the pattern of the lining can both be good predictors for implantation. What we saw in our center when we looked at our data was, interestingly, if each patient had the normal evaluation, which we do, every patient gets a saline sonogram and every patient undergoes a stimulation protocol aimed at achieving that lining. If a patient had that evaluation and with our standard protocols and adding supplements such as vitamin E or having the patient do acupuncture, if ultimately the best lining that that patient could achieve in the second or even the third try was below 8, we still saw excellent pregnancy rates, assuming that they had gotten that full evaluation. So I think that we love a lining that's 8 to 12 millimeters. We love that trilaminar pattern. It makes us super happy. Each of us still tell patients how gorgeous their lining is when we see that. But implantation rates can be fine in patients who are lower as long as we're not missing something. Is that lining thinner because they have scarring within their uterus? Is the lining thinner because this isn't the right stimulation for them and their estrogen receptors within the endometrium want to be stimulated differently? So we will often try multiple protocols to get that ideal lining, but we were very happy to see within our own center that as long as we do our best to maximize it, it may take 1 or 2 cycles to get there. If we see that the best that this patient can do is a 7.2 millimeter lining, she was not compromising her outcomes compared to the patients who do get that beautiful 8.5 millimeter lining.
Very good.
You know, one thing I agree with everything Dr. Walk said. One thing I would sort of piggyback onto that idea is that, you know, if you have that trilaminar appearance, but it's a thinner lining, that's actually a better prognosis than if you have a thick lining that's not the trilaminar. You know, like if you're looking at which one would you rather have, which you'd rather have nice and normal, of course. So I think that the other thing is I certainly have patients who've had, you know, whatever, damage to the uterus prior from prior DNCs or whatever, you know, maybe causing them to have a thin lining. Sometimes it just happens. You know, sometimes those are situations where I certainly have a group of patients, and I'm sure Dr. Walks does too, where you can't get their lining above 5 or 6. You just, like you try all these protocols, you just can't. And those are certainly patients that I will sometimes do an endometrial receptivity assay to sort of prove that they can get receptive. And those patients do very well, even with 5 millimeter linings sometimes. So, you know, obviously 8 millimeters is a great goal, but, you know, and if it's your first time going through an FET prep and you're not getting there, then obviously sometimes we have to adjust things or cancel things or change things. But if you're somebody who just can't get there, then, you know, don't lose hope. You certainly can still get pregnant, probably.
Very good. Thank you so much. Miriam, next question.
Next question is from Jess, and she asks your opinion on acupuncture and its effectiveness during different stages of IVF.
I'll start with the, yeah, good.
Okay. So a large percentage of our patients do acupuncture, so we're very familiar with it and we're familiar with its role. I think that the data supports acupuncture. It is sometimes neutral, sometimes positive, but there is little to no data that shows there's a downside. So what I usually tell my patients is, if they enjoy it, if it's a relaxing part of their week, if it's something that they feel compelled to do, I support it and I think it can have a very important role. If you're already strapped and racing to appointments and have no time for acupuncture, and making your acupuncture appointment is going to be more stressful, and another part of all of this process, which is actually taking away from your ability to feel more relaxed, then I don't think there's a terrible downside to not doing it. Many patients will add it. It brings different approaches. Sometimes we can't cure a thin lining. Sometimes acupuncture will be a great way for patients to check in mid-cycle, review how their follicles are growing, and see if there's a role for acupuncture in terms of increasing blood flow. So I would say I support it. Many of our patients do it, and I think there is absolutely a place for acupuncture in fertility.
I don't have much more to add. I mean, I think that the data is a little bit mixed. I think that if you're somebody who can't do acupuncture, you shouldn't feel like that's going to be the thing that makes it or breaks it. I think that there's very clear data showing that patients feel emotionally better doing acupuncture going through treatment. But I think that if it's something that you like, do it. If it's something that is stressful or you don't like it, don't do it.
Very good. We're going to take a little pause before we go to the next question. We're going to look at the poll. Here is, Miriam, can you take us through the poll results?
Sure. The first question was asking if they're currently seeking any fertility treatment, and 74% of our attendees were, 26 were not. The second poll question was, how comfortable do you feel about starting treatment during COVID-19? 52% of the attendees said somewhat comfortable, 39% were very comfortable, 10% were not comfortable. The third one was, how interested are you in knowing your likelihood of IVF treatment success? 87% were very interested, 10% were somewhat interested, and then 3% were not interested. And then the last questions was, what are your expectations with your ongoing or future treatment? And this was a multiple choice. 52% said better communication and support from my doctors and clinics. 81% more information on my treatment to help me understand my success rate. 35% conceiving during first treatment, and then 6% said other. And that concludes the poll.
Thank you so much. As you see, I think most of these, feedback that we get from the poll is that patient wanted to know a little bit more about their success rates, right, and chance of succeeding, which is, it's a real challenge for you guys to kind of come up with that and meet the expectation. Tell us a little bit what you see in the poll and how would you address it as a physician?
Two things that stood out to me. The first is, in some ways, IVF with PGTA is, I wouldn't call it the great equalizer, but I would call it pretty close to that. So each IVF center knows what are their pregnancy rates if they transfer one chromosomally normal embryo. And as I mentioned, the grading of that embryo is important for sure, but if your embryologists are biopsying and freezing good quality embryos, then the nuance between the pregnancy rate of the span of your embryo shouldn't be that broad. So I think it's much easier for fertility doctors to quote their success rates if a patient is doing IVF with PGTA. That makes it simple for us. We know what our outcomes are. It's a little harder for a patient who is trying with IUI, who is thinking about doing IVF and is worried, if IUI didn't work, what are my pregnancy rates with IVF? And we do our best. I think there's a lot of fear for patients. They want to know it's going to work, or they're afraid to try. And as I'm sure Dr. Rogers will agree, most patients get pregnant. We are in a really wonderful field now. And I'm giving good news so much more of the time than I'm giving bad news. So sometimes I think our role is convincing patients, try. We're not going to lie to you, but your chances are better than probably what you think. And often fear of it not working can be one of the things that's preventing you from starting. Actually, I'll see if Dr. Rogers has anything to say on that, and then I'll make my second point.
I do think that it's really, just to sort of piggyback to what you said, I do think that, patients, obviously we do our best to try to quote what we think a patient's chances of success are. In any given cycle, it's either 0 or 100, right? I mean, in any one cycle, you're either pregnant or not, and we have to sort of pool that data, but patients who continue with treatment are successful. And obviously there's reasons to stop doing treatment, financial, emotional, physical, right? I mean, but patients, there's a lot of pathways there, right? And I think that every doctor wishes that their patients would get pregnant with the very next cycle that they're doing, but there's a lot of treatment strategies and a lot of options for patients. And, patients listening to this, you need to know that you will be successful at the end of this journey. I can't guarantee it's going to be with your eggs or your uterus or, whatever, but there are a lot of pathways to parenthood. And I just feel like when I was going through my fertility treatment, I wish someone had said that to me. It's going to be okay. You will get there. And, you know, sometimes it takes a couple cycles to find the right embryo, right? Find that right egg. But I think that, you know, really being able to talk with your doctors is really important. One of the other things that stuck out to me in this poll was certainly the fact that it seems like patients are really interested in sort of knowing what their chances of success are and really having good communication with their teams. And obviously in a day and age of texting, portals, you know, emails, all the things, you know, it's really important to have that personal connection with your team and to know that you have a team that's listening to your concerns, that is able to discuss different treatment options with you and really work together with you as a team. I really see my role is not telling patients what to do, but educating them about what their options are so that they can make choices about what they do. And sometimes they do not the thing that's going to give them the highest chance of success, and that's okay. My job is to sort of be their coach, and then they're the ones deciding what to do.
I agree. One other thing that stood out to me from the poll was it looked like, I think it was 52% of patients only felt somewhat comfortable proceeding with treatment in COVID age. So two thoughts around that. The first is, if it's more of a fear of pregnancy rather than actually starting fertility treatment, I just wanted to again mention, you can freeze your embryos and you can wait as long as you want to let COVID rear its head and let us learn what's happening. And then the second thing is, if you're hesitant to start because you're nervous about going into the doctor's office and about the actual treatment part of what helps me fall asleep every night is I feel like going to work each day with my mask on and knowing that I'm screening all of my patients. But I also know that our patients are the most motivated patients to be healthy. And if you're going to be going into a fertility doctor's office, that's probably a heck of a lot safer than walking into any grocery store or out and about in the public where people may not necessarily have that high level of caution. But our patients are all super, super vigilant because they want this so badly.
Very good. We're gonna take one more questions. We're approaching the end of the webinar, but I think we're gonna take one more questions. How many questions do you have in your list, Miriam?
I actually have, since we're on the topic of COVID, we actually received a COVID question from Teresa. She said that her husband is very worried about the impact of COVID-19 on sperm health. Is there any evidence that getting the virus impacts sperm or egg viability?
I'll jump in. So no, I'm not aware of any data that has us concerned about a long-standing impact on sperm health with COVID. If a man were to contract COVID, he may choose to wait the 2.5 to 3 months until brand new sperm is being ejaculated before doing treatment. But I'm not aware of any data that shows a decline in sperm function or quality from COVID.
I would agree with that. The other thing is that anybody who has a fever, so if you're somebody who has COVID, it's asymptomatic or has low-grade fever, is probably fine. But if you're someone who's really, really high fevers themselves can very temporarily decrease sperm quality. And like Dr. Rock said, it usually is, done, gets out of your system in about 10 weeks or so. But, that's why we don't like excessive bicycle riding, and we don't like hot tubs, we don't like saunas for that same increased temperature. Sperm like to be made a little bit cooler than body temperature, which is why the testicles are outside the body and lower and raised to control their temperature. So sperm really like to be made in a cool environment. And when we have fevers from infection, then that can decrease sperm function.
Thank you so much. We have so many questions coming from patients as we speak. Unfortunately, we are not going to be able to cover all of them, but I promise you that in the next webinar, we will have a chance to aggregate those questions. We are approaching the end of the webinar. I would like to give both Dr. Rogers and Dr. Wachs the opportunity to introduce your practice and tell us a little bit about what you do for patients. And I'll start with Dr. Rogers.
So I'm Dr. Allison Rogers. I am at the Fertility Centers of Illinois. We are, like I said, an 11 doctor practice in the Chicagoland area. Like many large practices, I do take care of patients around the country, and telemedicine is pretty awesome for that. Obviously, we try to, be on the cutting edge and really try to individualize care so that there's not a lot of sort of cookie cutter medicine, really taking each patient, and I'm sure Dr. Walks does this as well, but taking each patient as their own situation and coming up with treatment strategies. There's some other cool things that I do on the side. I'm involved with the podcast Beat Infertility, which can be a great source of support. I am pretty active on social media and really try to educate patients about what their choices are.
Thank you so much, Dr. Walks.
I'm part of Reproductive Science Center of the Bay Area. We are a 6-physician group. We have 4 offices. I am mainly in our Los Gatos office, and I'm there with one other physician. We basically have 1.5 to 2 physicians who cover each of our offices. I am so proud to be a part of our group. We have amazing chemistry between the physicians. We get along really well and we work really collaboratively. I like patients to know that when you go to a practice with multiple doctors, you have the benefit of multiple brains, and we talk to each other all the time about tough patients. If we have a patient whose cycle didn't go as we expected, an email goes out and all 6 of us are chatting back and forth. We even have a meeting every month where we specifically talk about patients who have been challenging, and each person is able to give their input, talk about their experience with patients maybe in a similar boat. So I feel really proud to be a part of this practice where we have such great collaboration. I am really hands-on. It sounds like Dr. Rogers and I practice similarly. I think my patients feel really heard, really taken care of. I try really hard to communicate throughout the entire cycle so that they know how things are going. I think one of my roles is to try to take what has been a really stressful process and try to make it less stressful, because the patient knows I'm on their side and I'm going to be the one to navigate all of the ups and the downs with them to try to give them the smoothest path and the highest chance that ultimately they will be pregnant. And like we said before, most patients are.
Fantastic. Thank you so much. Let's look at the results of the last poll that we have received. So we asked the audience if the webinar helped them solve some of the concerns they have. 64% said yes, 32% say somewhat, and 5% said no. And we asked them if they would like to see a webinar like this in the future. 86% said yes, and 9% said somewhat. So with that, I would like to thank both of you for bringing such a wealth of knowledge and expertise, and that's how it's translating into these feedback from patients. We are coming to the end of the webinar. Next week on Wednesday, 3 p.m. Pacific time, we will have another webinar. We're going to get some of those questions that we didn't have a chance to answer today in that webinar. I would like to thank both of you, Dr. Rogers and Dr. Walks, for your participation and your help. Thank you so much, and I will see you next week. Thank you.
Thank you so much for having us.
Thank you very much.
Thank you.